Good morning, everybody. This room has such a buzz about it. It is an absolute pleasure for me to welcome you all to this very special World Cancer Day event. I know lots of you, but just for those I don't know, my name's Gemma Peters and I'm Chief Executive of Macmillan Cancer Support. So you're in this room because you're special. And you are special because most of you have very personal experience of cancer. In fact, I'm going to say all of you. I think probably everybody has a very personal experience of cancer. But more than that, you're also people who are active and doing things to make things better for people with cancer right now, and so that the people that come after us have a better experience as well. And I look around the room and I see charities who are doing incredible work, community groups, senior people from high street organisations, medtech startups, loads of professionals. Like, this room is full of people who really sadly don't very often get into the same room, but are united by one thing, which is about making life better for people with cancer. So I couldn't be more proud that you're all here, and I cannot wait till the bit afterwards where we get to chat and catch up. You also know better than me, as well as me, that things for people with cancer right now are pretty tough. You know the stats, you know there are 3.5 million people, almost 3.5 million people in the UK with cancer, and that those numbers are going up. You know those people are facing into a system that's struggling, where people are really struggling to deliver the care that they want. You know that the gaps between the very best of what we can do in this country and the very worst are widening. You know there's incredible hope on the horizon. You know there's new technology and new treatments, but you know that that's making pathways more complex for patients. And you know that we're here because there's a lot of hope, because we've got an opportunity as a group to redefine what cancer looks like for this generation with the new cancer strategy that I'm sure we'll talk a little bit more about. We've got two people on the stage who you might recognise. They're here for lots of reasons. They've both got very personal experience of cancer as well. And they both have, in different ways, a responsibility for holding us to account and for making the cancer experience better. So it gives me such great pleasure to welcome Nick Robinson, esteemed broadcaster and Secretary of State for Health and Social Care, Wes Streeting. Thank you both for being with us.
Gemma, thank you very much indeed. I'm not sure one should say happy World Cancer Day, should you? But happy because we're here, happy because everybody's here with, I think, a shared goal and a shared mission. And I know, Wes, when you and I first talked on my Political Thinking podcast, we bonded, I think, because in our own ways, we'd both been through what I think we now have to call the cancer journey. And we both came out the other end with a lot of luck and quite a lot of happiness, but with a determination that things should be better. We would do what we could to make it better. And of course, you now, on this day of all days, have quite an important announcement to make about a cancer plan to try to do just that.
Yeah, that's right, Nick. And I think in some ways, Happy World Cancer Day is the right term, because even set against the enormous challenges facing the NHS, which is going through what is objectively the worst crisis in its history, cancer outcomes are much better now than they were decades ago. There are huge grounds of optimism about the future, particularly in the way that life sciences and medical technology are pushing through the frontiers of our understanding about cancer, its causes, how to diagnose it more quickly and more accurately, and then how to treat cancer either through effective treatment to point of cure, or indeed life-extending cancer treatment as well, which is also important. So there's an important message to say to people, particularly those who are worried that they've got some telltale signs that could be cancer. There's an important message, first of all, to say, if in doubt, go and check and do it quickly, because the earlier we can catch it, the more effective the treatment, the more likely a successful outcome. So cancer is no longer the death sentence that it once was. And so there is an important note of optimism to share on World Cancer Day. We're determined to put our foot down on the accelerator particularly in terms of the life sciences and medical technology. Just today, we've announced a trial using AI to improve our diagnostics for cancer, which would be an absolute game changer. I mean, 700,000 women, just looking at my stats here, 700,000 women will be involved in this trial using AI to reduce the number of radiologists involved in the screening process. I mean, that could be transformational in terms of breast cancer outcomes in this country. It can double the, if you think you can reduce, of the 2 radiologists that might be involved in diagnostics, if you can take one of those out of the equation because the other has got an AI co-pilot, we've just doubled capacity in a stretched workforce. I mean, that is a huge productivity gain, but it is also, more importantly, a huge driver for patients' access to diagnostics, and faster diagnosis means far better outcomes. So lots of reasons to be optimistic. I think the other thing I would just say, though, is the kind of the note of caution, really, which is that, back to that NHS crisis I mentioned, I think cancer has always been the canary in the coal mine for the NHS. When the NHS is performing well, its cancer diagnostics and its cancer treatment pathways work well, and we see that reflected in the speed in which people are accessing their diagnosis and their treatment. Cancer care worsened every year from 2010 in one way or another under the previous government, and that should have been the canary in the coal mine that showed a worsening NHS to the point of the crisis we see today. And so it's really important for me to do 2 things in the immediate future. One is to get the NHS back on its feet. So last week we published our mandate for the NHS, and the NHS published its planning guidance, which is all about making sure the NHS gets back to basics, fixes the fundamentals, and creates that rising tide that will improve the experience for all patients, regardless of their conditions, regardless of where they live, regardless of their background. But we're also keeping that focus on cancer, because I genuinely think that if you're getting the diagnostics right in cancer, if you're getting the treatment pathways right in cancer, you're improving things right across the board for all patients, actually, which is the power of the cancer pathway. And that's why today we are launching the call for evidence and the consultation on the new national cancer strategy that we will put in place, so that right across the board we can improve the quality of diagnosis, the quality of treatment, the quality of outcome for all people living with or affected by cancer.
So in the next few minutes, it would be good to go through how you plan to develop that plan. You've mentioned tech. That's one of the big things that I know you care about in reform of the NHS. The other you've talked about is moving from hospitals to community, and I want to talk about how there could be greater community involvement. And we've got some friends, colleagues here who've got some stories to tell on behalf of themselves and Macmillan about that. Let's just start with the bigger picture, though, if we could. And we can do this briefly, because in a sense you've already acknowledged the scale of the problem. The tension for someone like you is short-term, long-term. You've identified the crisis in the NHS, you've talked about it being broken. People see the new planning guidance and they go, oh, hello, they've kind of weakened the commitment on some of the early cancer diagnosis. It's slipped just a little bit. How do you get the balance right between the need to, as it were, get the NHS back on its feet, to use your language, and the desire that people have in this room that Britain should be, and England in the case of the NHS when we're talking to you, should be like Denmark. It should be making a step change, big improvements, not merely struggling to get up to date with existing targets.
So I'd say 2 things. Firstly, we certainly haven't deprioritised cancer. The cancer targets are still there in the planning guidance. The faster diagnosis standard is there, and at the moment currently being exceeded, although we want to keep that progress and continue to improve that. The 62-day standard, which is not being met and where we want to see considerable improvement, those are still there in the NHS's planning guidance.
They're watered down a bit.
Well, we've dropped one of the 3 targets in the planning guidance, which is effectively the middle bit but the 62-day target, I think, more than covers it. And why, and this particularly applies to actually conditions or patient groups which are not cancer, which are not in the planning guidance. We've had a culture for a few years, good few years now, where in order to signal something is being done about something, our predecessors slapped it in the planning guidance with a target. Said, aren't we doing well? Look, we've got a target in the planning guidance, such as the importance we attach to this issue. And we are weighing down the NHS with targets. And if you're measuring everything, actually you're measuring nothing. And there is a real problem, I think, with the fact that at a time when ambulances are not arriving in a timely way, to the extent people are dying waiting, people are waiting more than 12 hours in A&E with a to detriment to their health and well-being. People can't get a GP appointment. People are waiting far too long for elective treatment. We have not got the fundamentals right. And what I will continue to do is resist the demands that we try and boil the ocean instead of taking a focused, planned, and consistent improvement to the fundamental things that affect all patients with all conditions.
So people are
not get dragged off with blurred visions, trying to do everything for everyone, everywhere, all at once, because that is the path to failure, and we won't do it.
So just so we've understood, because I think we have, you're basically saying people who obsess about this or that target and say, oh, well, 5% here or there, you think that's the wrong way.
Well, there's a cottage industry. There's also a cottage industry in this, let's be honest. There's a cottage industry for people involved in lobbying for whichever organisation or another that says to their employers, their trustee boards or their clients, I've done a really good job today. Do you know why? Because I've got a target in this particular document here. Well, so what if the target isn't met and you've not changed anyone's lives? The important thing is to improve the fundamentals of the system. And if we don't take this approach, we'll fail as our predecessors did.
So then take the other half of the question I asked you, which is that people think, actually, we want a step change in terms of improvement. And they look at Denmark, which had rather similar performance to the English NHS when it came to cancer, i.e. not nearly good enough, with other countries around the world, particularly in Europe, doing much, much better. And they say, will this cancer plan be, frankly, a new cover on a list of existing NHS England plans, or will it actually be some new thinking about how to radically change the way in which we improve diagnostics and therefore survival rates?
Yeah, it needs to be the latter. And, it kind of relates to the previous point actually about planning guidance. One of the things that I am doing is trying to blow like a gale, like a breath of fresh air through all of the old cultures, ways of working that led us to the crisis that we are currently trying to get ourselves out of. So that's kind of clearer priorities and more focus, but also completely shifting the way the NHS operates as a kind of gigantic state monopoly in huge top-down direction, and with a conviction that we can decide in Westminster and Whitehall how to improve health outcomes in diverse communities right across the country with completely different needs and challenges. I don't believe that. So one of the big shifts we will see over the course of the NHS's 10-year plan, which we'll publish later this year, is a big shift from central to regional, local, and working with communities, because I genuinely think if we're to improve the health and well-being of people right across our country, we should recognise that decisions about how services are designed and delivered are better taken closer to the communities that they serve, because the needs of the population, the design and delivery of services will look different in my part of the world, which is North East London and West Essex, than it will for Cumbria or Cornwall.
So what do you do to deliver that? Because every government said it. I mean, I was looking back, it's been stated NHS policy since 2006 to move money from hospitals to the community, and in that period, the spending on hospitals gone from 47% to 58%. So the reverse has happened to the stated policy, not because people are insincere or didn't want to do it. I think the worry lots of people have in this room is that when they hear you say, go to community, it just means an NHS branded bit of kit or hub or centre in, as we'll hear in a second, a Leicester or a Coalfield community, where those people follow NHS guidance from Whitehall and that local people who know what they're talking about get no say at all. How do you break that?
Well, I think that's where the kind of approach to the way we set targets, but also it is about culture and it is about financial flows and incentives. Sorry to go very technocratic at this time on a Tuesday morning, but this is a system where money talks. I've never seen anything like it. It's a system that's meant to be cuddly and altruistic. But money talks in the system, and so the way in which we redesign the system and the way that it works, the way in which financial flows operate, and crucially where decisions are taken, that has to change. And that's not just about from national to regional and local, it's also about the way in which we empower patients and patient communities, the relationship the NHS has with other parts of government, particularly local government, but also the voluntary and community sector, who I think have got a role to play, not just in terms of advocating for patients and patient groups, but also actively designing and delivering public services. If you take Maggie's centres, for example, like I genuinely think that if Maggie's was an NHS-provided service, it would not be as good as Maggie's. It just wouldn't be. The NHS is not set up culturally to design its services in that way. In fact, Maggie's wouldn't even describe themselves as a service provider, and yet they are doing something powerful and transformational that should be a universal offer for people living with cancer or indeed loved ones affected by cancer, which is another big group in this conversation who far too often get overlooked. If I think back to my cancer diagnosis, I actually think it was a lot harder on my partner and my parents than it was on me, actually, in a funny way.
And how do you voice...
So I think that's where the VCS really comes into
And how do you voice those people? Because when you've talked about your cancer, you've talked about the fact that you were sent for the wrong scan at one point, that follow-up appointments were often delayed. But you talked, I thought, very movingly in an interview you and I did at the end of the Labour Party conference about a constituent of yours whose late diagnosis was critical. It meant that there was no chance of successful treatment for him. And I suspect part of the reason is, unlike you, unlike me, not well-established, able to use their voice, articulate, middle-class, well-connected people who can make the system work for them if they really need to. How do you give voice to those people in a system you've just described as a statement audibly and top-down?
Yes, so, I mean, that's the, I'm sure I'm not the only person who feels like this, that's the sort of survivor's guilt I feel, actually, about my cancer experience, is that I was just incredibly lucky. I mean, thanks to kidney stones, my kidney cancer was discovered on a visit to A&E in the middle of the night at my local hospital. Ironically, the A&E campaign, the A&E campaign to save, so I definitely benefited from that particular campaign. And so it was caught really early, and okay, I knew I was going to have one of my kidneys whipped out, but in the grand scheme of things, apart from, the fact my, no doubt, hugely successful potential career as an swimwear model has been ruined by some cancer scars. Keep it quiet. I had a really lucky experience. I've got nothing to complain about, really. And even those bumps along the road with the NHS experience, really, nothing to complain about. There's something for me, there's a few things. There's definitely like the system change that's needed. And holding to the faster diagnosis standard, making sure we're holding people to the 62-day standard, those are really important system changes. Similarly, the quality of the diagnostics equipment, the efficacy of the treatment and the way in which we're deploying new science, new medical technology, those things are important. But there's also a cultural issue here that some of us were talking about just before we began today, which is about being listened to as a patient. Like, that is a cultural change that's needed in the NHS. It affects people with a wide range of conditions, but it also affects people with cancer, especially if they are from a community or a background that is where cancer is less prevalent or where certain types of cancer are less prevalent, but also applies, I think, frankly, to lots of women for whom cancers and other conditions they might be suffering from are actually very prevalent. If the clinician isn't listening to you, they're more likely to lose sight of what's really going on. If you're making assumptions about the patient in front of you, particularly young people with cancer, because you've got a lower risk profile. Don't dismiss what the patient in front of you is telling you about their lived experience of change that they have noticed or experienced. Ask the questions, be inquisitive, do the investigation, and don't provide false hope or false reassurance. Oh, it's not going to be cancer. You can't have cancer. It's low risk. It's not no risk. So part of this is about systems and policy change, but this is also about culture and an NHS that listens to its patients.
Yeah, when I'm listening to you, I'm thinking, I think a lot of people in the room will be thinking that, as it were, in that cliche, you get it. What they might think is, how in Whitehall do you make the damn bit of difference to what's happening in the communities that people here represent in terms of the services they get? What is it you can do? You see, the great advantage of doing my job is a disadvantage too, is I basically go from health secretary to health secretary, perfectly decent bloke, clearly wanted to do right. I mean, I'm happily not burdened with having to choose sides. I generally meet these people from Tory, Labour, Liberal, all reasonable people. They all listen. They all want to do something. They're all pretty sincere, actually. But the system doesn't change. And I'm just trying to work out what it is you do in this cancer plan, who you listen to, what you do. That doesn't mean that they'll go, no, well done, Secretary of State, and then they just plough on.
So I'd say two things in response to your typical journalistic cynicism. I would say it's all very well for the journalist, isn't it? Oh, well, what are you doing about it? Well, you just have to ask the questions. We have to answer them. It's nice to have the shoe on the other foot for once, to start giving Nick a hard time. I'd say a couple of things. Firstly, one of the things that gives me confidence that it can be better than this is that we've done it before. The last Labour government did deliver the shortest waiting times and the highest patient satisfaction in history, and delivered the cancer guarantee, which was game-changing in terms of people's experience of cancer and cancer outcomes. So we have been here before. And things did change, and it wasn't easy and it wasn't without opposition, but the last Labour government did have a bold reform agenda. Our Conservative predecessors, and you're right, many of them decent people, don't go in for this sort of our opponents are our enemies nonsense, and there were plenty of decent people I faced in the House of Commons doing my job previously. But Conservatives like Robert Jenrick and others have acknowledged that actually, for a Conservative government, NHS reform was the third rail. After the Lansley reforms, which were a disaster, and I think that's kind of widely acknowledged across the political spectrum now as a disaster, they just backed off NHS reform altogether, poured quite a lot more money in, especially after 2019, but we didn't see the results. Why? Because the investment has to go with reform and modernisation. And that's where I think only a Labour government can reform the NHS and be trusted to. We have to do it with people. And we will certainly do the cancer plan with all of you. But we also,
can I bring some of them in?
Yeah, absolutely. The final thing I'd just say, though, is the revolution we need to lead is to make sure that the National Health Service is doing the things that only the National Health Service can do and is being a genuinely national enabler, and that particularly applies in things like life sciences and technology, where actually Bevan and Attlee couldn't have predicted in 1948 how advantageous that model would be here in the 21st century. But also Herbert Morrison, for those of you historians of the foundation of the NHS, Herbert Morrison, who actually argued for a much more decentralised local NHS, had a point. So the Labour historian in me would say what we need to do is a Morrisonian correction to the Bevanite foundation. The retail policy, oh no, that'll get everyone going. The retail politician in me would say what we need is the biggest revolution in the NHS's history, and a huge shift from central to local, a big shift from hospital to community, from sickness to prevention, from analogue to digital. That's the agenda, that's the plan, and that's what we'll deliver.
I saw the BBC Health editor here. We've finally given him the news story he insisted I got. Headline on the 10 o'clock news, Morrisonian correction planned to Bevanite solution. Excellent. Job
Morrison
done.
and Bevan united after 76 years.
Let us move to the people who you rightly say you want to listen to. And, I think you know this, but what Macmillan Cancer have done a lot of work on is saying that it is often the people in communities that don't get listened to who have the worst outcomes for cancer, get listened to the least, and want to be most involved in the design of policy. So I've said, and forgive me, because there's always a danger that people talk to someone like you, and will you forgive me if I point this out? They've written out a question.
Yeah, sure.
These are incredibly articulate people. If you threw that question on the floor, you'd know what to say to the Health Secretary. And I think he agrees with me. You've got, what, 15 minutes now? So that in a week's time, he goes, I remember that person who told me this. So let's not be too polite, and let's not just read out the question to ask. What do you want him to know? What do you want him to remember? So that when someone's giving him the old blah blah in Whitehall, he's got the voice, let's start with the Coalfields Regeneration Trust.
How did you know?
He's got that sense of, yeah, do you mind if we start with Anne, and then I'll come back to you?
Sure.
What do you want him to know?
No pressure. So I work for Coalfields Regeneration Trust. That's an organisation. We're a charitable organisation. We've been very lucky to be funded by Macmillan Cancer Support Services. And what I do within my role is I make sure that we support people. It was strange that you said earlier, or quite funny really, that you spoke about the journey. The people in the most deprived areas of the valley don't see cancer as a journey. They say to me, don't call it improving the cancer journey, Anne. We didn't choose to come on this. The journey is going on holiday or catching a bus somewhere. It's my role to work with people within our most deprived coalfield areas to look at all the practical issues that come from a cancer diagnosis. I'm going to give you a live story of a gentleman, ex-army veteran, living in the Rhondda Valleys, walking 25 miles a day for his cancer treatment in a local hospital, walking 25 miles a day back. It was my job as the manager of this programme to make sure that didn't happen. There are local cancer services within our communities who offer free transport. They can't sustain this forever and a day. He now gives something back, and he's now a volunteer driver for them. The role that we have within our communities is trying to make that difference. So my question to you is, how are you as Health Secretary going to make sure that these community organisations remain sustainable and continue, because the trust that my coalfield communities put in me as the manager of this programme is, they say to me, yeah, but you've really gone. I need to promise that I won't be.
Anne, thank you very much.
Yeah, I think that tells me two things. One is, and I think what you're saying is kind of grist the mill of the need for services to be designed and delivered with and closer to the communities they're serving, because the needs in the communities that your organisation works with will be different from the challenges in my part of London. And the second thing is that, like, this isn't just about the NHS, it is about the wider, like, kind of health and care system, which includes community organisations like yours who are providing real benefit and added value. And we've got to work really closely with voluntary and community sector organisations, treat them as real partners in the delivery of support for people, as well as taking on board the advice and insight you'll give on behalf of patients. Because certainly in my experience, patients don't have a particularly loud voice in the system, and voluntary and community organisations provide it. I think the final thing I would just say as well is the conditions you're describing speak to the underlying inequalities in our society. And we will not improve health outcomes for people in our country unless we improve the wider conditions of poverty and inequality in our country. And that is why I would also say, in terms of the budget we had, £26 billion going into my department, that will make a big difference, but it's not been without pain for people paying those taxes, which will include voluntary and community sector, by the way, as well as businesses. And also, when I look around the cabinet table, there are colleagues who are responsible for tackling things like poverty and inequality or improving transport services. So every penny that we get in health and education is an opportunity cost somewhere else. It could have gone to another part of government that often is tackling the causes of ill health, but it's also been taken from the pockets of people who might also need the money. So we've got to make sure that every bit of money in the system is well spent as well.
It's interesting, preparing for this and knowing what Anne was going to ask, Macmillan were telling me that they do something called electronic holistic needs assessments. I don't know if that is something that you've come across, but it's about developing a care plan with a community link worker, which might be the transport, or it might be something else. And again, I think the question that you'll see, let's come to Alia now, is whether, as you rightly from the centre say, let's get the diagnostics right, let's get the radiologist and the oncologist we haven't got that we need. If the guy's walking 25 miles, none of that's actually going to help. What about in your community, Alia? What's it like for you?
Hi, Wes. My name's Alia. I'm from the At-Taqwa Cancer Support in Leicester. I'm 4 years in remission for cancer, and 2.5 years ago, I started a cancer support group for people in my community because when I was going through my journey, I couldn't find the support that I needed outside of my family network. I'm very privileged, but there are people who are not privileged as we are. So my question to you is, looking forward, what is your vision for how the NHS can better address the needs of ethnic minorities in cancer care and support? And how will these changes be measured to ensure progress is being made?
Yeah, those are great questions. I mean, firstly, and you'll see this in the 10-year plan for health inequalities is a big part of our agenda, and making sure that we close the gap in outcomes and experience for people from different backgrounds is really important to us. I mean, if you know, in the area of kind of racial inequalities in cancer care, I mean, we've got particular challenges in terms of prostate cancer, myeloma, blood cancer. So I think we have to look at this through a kind of condition-specific lens, making sure that the advice on symptoms is relevant to everyone and highlights particular risk factors. But even in areas where there might be lower risk factors or lower prevalence, like with skin cancer, for example, that doesn't mean that when we are showing people the telltale signs of skin cancer, that we shouldn't be showing those on different skin tones just because Black and Asian people might have a lower prevalence of skin cancer than I would, and people from my background would. So I think we've got to look at this kind of intelligently. Experience also matters. So are we listened to as patients? And would my experience of being listened to be the same as yours in the NHS? I can't say with certainty that it would. In fact, I could say with some degree of likelihood based on the data, it may well not be. So we've got to be honest about that. And we've got to deal with these challenges against the backdrop at the moment, let's be honest, where equality, diversity and inclusion is under a lot of spotlight and discussion, and where prior to the general election, I could have, in fact, now I could get quite a lot of plaudits from quite a lot of people across the country if I said, you know what, NHS, tough times, I'm going to scrap all of those equality, diversity and inclusion people. We'll save loads of money doing that, and we'll divert the money into actual patient care. Except that, ask Black nurses about their experiences of being bullied in the workplace in an organisation that has had Black people in it since it was founded pretty much, Empire Windrush, NHS Foundation, same year. That generation built the NHS. You look at those outcomes, prostate cancer, Black men twice as likely to die in childbirth than with prostate cancer than white men, Black women 3 times more likely to die in childbirth than white women. We've got some real racial inequalities here. Now, I think we've got to refocus
this is a
that
fight,
work.
your political fight you're willing to have. You're willing to say, I know this is popular with certain people. Reform's gone ahead of the Labour Party today, but you're willing to say, no, I'm going to fight for that.
Yeah, but I also need the profession to help. And sometimes there are some really daft things being done in the name of equality, diversity and inclusion, which undermine the cause. For example, there was one member of NHS staff who was merrily tweeting a job ad online and saying part of her practice was anti-whiteness. And I just thought, what the hell does that say to the bloke up in Wigan who's more likely to die earlier than his more affluent white counterparts down in London? We've got real issues of inequality that affect white working class people, particularly white working class men and boys.
I think diversity and equality, if it's improving health outcomes, not so people can pursue a political hobby horse.
The ideological hobby horses need to go. The whole point about, and what's been lost, I think, with some well-meaning but misguided approaches to equality, diversity, inclusion, the clue is in the name. It's equality. it should be applicable to everyone. And where we see health inequalities, whether they affect men and women, black people, white people, rich, we've got to take a much more evidence-based approach to those inequalities and say, if you're on the wrong end of the stats, we want to deal with that to make sure we get equality of outcome. And I was really frustrated just last week to see the government's commitment to have a men's health strategy juxtaposed against women's health, as if by focusing on the inequalities that affect men or the issues that affect men, that somehow we'd be deprioritising women. I don't think that's how my sister would feel about my health, and it's certainly not how I'd feel about her health. So I think we've got to take a much better approach to this issue. So a part of what I'm doing is kind of trying to win again the fundamental arguments for equality, diversity and inclusion when they're under attack.
Sorry to rush you. We've got 3 more questions we want to get through in about 5 minutes, so we just need to be relatively quick. Temi, yeah.
Hi, Wes. I'm Temi from Maggie's, and it was great to just hear your acknowledgement of what we do and the work that we provide. What I wanted to touch on and ask is do you agree that the cancer plan must invest in supporting people to live well with cancer and providing a personalised cancer care? And for organisations like Maggie's and Macmillan that provide wraparound support, looking at sort of the holistic care of individuals, that work will be sort of reflected in the strategy. How do you envision that?
Temi, do you mind if I bring in Ruth at the same time? Because I think, in a sense, there's a common theme here that I was hearing from you. Ruth, is this fair? A fear that in the desire to get speed of diagnosis that everybody in this room wants, because it improves survival rates, that you forget the whole journey and you forget part of the clinical journey as well. Ruth, tell us about your experience.
Yes, thank you. So seeing our, the increase that we see of referrals, cancer patients being diagnosed, etc.
I'm sorry, just tell the Secretary of State what you do so he understands.
Ruth, I'm a lead cancer nurse in Bristol. So yes, very much our focus on the increase of numbers of people that we see coming through our services and the increase in the complexity of the treatments that they're able to have, thankfully enabling people to live longer, many more people in the service. Our concern is when will there be adequate resource for the whole pathway to enable us to develop the specialised workforce so that, that we can absolutely see people through their treatment, but also into their aftercare beyond that. So examples being that the focus is so much on the diagnosis, early diagnosis and treatment, clearly, and resources so tight that nurse specialists, for example, pulled more and more to do those initial clinics, and then we've decisions to be made about actually need to stop doing some of that wraparound support potentially to meet some of the targets there to get the diagnosis.
Lovely. Thank you, Ruth.
Yeah, that's very well said. I'd say kind of 2 things. They are related. You don't normally let me rabbit on this long on the Today programme, so I'm sorry if I've kind of run down the question time. So I would say a couple of things. One is we do have to look at the whole patient and their wider needs. And one of the areas in which I feel really lucky about my own experience is that my job wasn't at risk. I had a good boss. He actually promoted me while I had cancer. So that was nice, and certainly something I'll never forget in terms of the kindness that my boss treated me, and I think that's not the same as lots of other people experience. I was okay in terms of my income, and I had someone at home who could help look after me, because let me tell you, I've got some feedback for the NHS on expectation management about what you'll be able to do in the immediate aftermath of kidney cancer and how quickly you can go back to work, even having had robotic surgery. I think that whole person, that holistic support is important. And I think these are exactly the sort of issues we should get into in terms of the cancer strategy and how we can try and bring that support together in the right way for people who need it. I mean, you know what my obvious caveat on all of this will be, which is about resources. We will go as fast as we can, but resources are a challenge, and it'd be dishonest for me to suggest otherwise. And that's why I'm going absolutely hell for leather at the moment on value for money and spending in the NHS and where there is waste and inefficiency. And to be honest, one of the other great things that the voluntary and community sector does with patients and bringing that patient's voice to the fore is identify those areas of inefficiency, to identify the gaps, the lack of join up in health and care services.
Just
so we
wanna
need
bring
your
in one
help
more
to do
person.
that so that we can make sure we're spending every penny that goes in on things that will really matter in terms of outcomes.
Forgive me, I'm aware of your time constraints. I want to bring in Tanya.
That's right, I don't mind running over a bit. It's
You-
my
okay,
fault.
okay, Tanya, thanks.
I'm Tanya Mishra. I'm here with Teenage Cancer Trust. I'm part of the Youth Advisory Group, and I'm 3 years in remission for blood cancer. In my work with Teenage Cancer Trust, I've been lucky enough to meet lots of other young people like me with lived experience of cancer from throughout the country. And the two things that have really stood out to me are just how much socioeconomic differences impact health outcomes, but also the differences in health outcomes between if you have targeted intervention, young people specific, versus those who are lobbed into pediatric or older adult care. Please could you speak to the specific actions that the government's going to take to bridge those socioeconomic disparities, but also ensure that young people are getting the care that they deserve?
Thank you, Tanya.
Yeah, I mean, I think we should be extremely vigilant about the trends we are seeing in cancer diagnoses among young people. I think the lack of awareness is leading to later diagnosis in too many cases. I certainly think of some experiences I've had in the last 6 or 7 months talking to people who've suffered far worse outcomes, and in some cases families who are bereaved as a result of the diagnosis being missed or not fast enough, leading to a fatal outcome. So that this really matters, and that focus matters, and we are establishing the Children and Young People's Cancer Task Force, which is going to be co-chaired by Caroline Dinenage, who's a Conservative MP, but pushed the last government into doing this, but before it got up and running, there was a general election. So but I want Caroline to stay on, because I think she's really committed to it. It doesn't matter what party she's in. And Darren Hargrave's going to co-chair that with, who's an oncologist. And I think we can look at a whole load of the issues affecting children and young people with cancer in particular, including, so if I think about, and I know you guys are campaigning on this at the moment, and we've got to take it seriously, this issue of travel costs, for example. Like, for kids from my background, I come from a very working class background, even though I'm living a very middle class life now. And those sorts of costs would have been kind of crippling or debt inducing for my parents. So I think we do need to take those sorts of issues seriously as well, and make sure that there is equity of access to services, especially where, and part of the big push in the NHS always is for kind of greater concentration in specialist centres. And there are good reasons for doing that, even if sometimes I think if it could, we'd have a massive city in the middle of the country called NHS City, and everyone would work there and we'd all go there for the benefit of the NHS. So we've got to make sure we get that right as well, and get the balance right. But where we are necessarily specialising and centralising, we've got to make sure those services are accessible and take into account things like, can you travel there to and from in a day? Is there accommodation that's going to be needed for a family member? Do they have the means to afford it? And these are a wider range of challenges.
Well, that brings me to a final thought. We're over time, and I think you've kindly said you can stay on a minute or two.
Yeah, my
But
team are going to go bananas.
let's just bring it to.
But it's my fault.
Bring it to a conclusion, which is, I think, and as you say, I have the great advantage of merely asking questions for a living rather than actually ever having to do anything at all, which is very much the easy option. But it seems to me there are some themes emerging here which are relatively clear to state, but hard to do. If you want to go down the Danish route, it's what you've just said, isn't it? It's centralise and specialise. All the evidence round the world, as I understand it, from proved cancer care, is centralise and specialise. And you can make dramatic changes, as the Danes did, to their result. But then you produce all the problems that these ladies and gentlemen have been talking about access and equity, transport, lifestyle, and so on. Is this cancer plan something you're going to sit at the head of? Are you going to be directly involved? And if you agree with me, what do you want them to say? Because I'm picking up a frustration from you, and it's some reported comments at the weekend, what people think they need to do in meetings like this, and I don't think anybody has, by the way, but is Oh, I must shout at him about, forgive me, because you didn't, young people or ethnic minorities or coalfield communities. When you want to get insights from them, what you don't want it to be is simply lobbied. Don't forget us, give more money for our specialty. What can you do to make sure you learn from these experiences as you draw up a plan?
Well, firstly, I think charities have got an important campaigning role, and it's right to challenge government, it's right to hold government to account, and it's totally legitimate for organisations to kind of campaign and advocate on behalf of their particular group, whether that's a condition or patient group, and so on. All I'd ask people to do as they do that is to kind of recognise two things. One is, I've only been in government for 5 minutes. It feels like longer. And secondly, to recognise because if this is a partnership, and I think it should be, part of partnership involves acknowledging the choices and the trade-offs that we're having to confront. And if the only thing this government had to do was to take the NHS from the worst crisis in its history, get it back on its feet and make it fit for the 21st century with all the challenges that presents, and build a national care service that's worthy of the name, those would be two enormous historic things. We have to do that, and I have to sit around a cabinet table with an education secretary with crumbling schools and not enough teachers to staff them, a defence secretary who's facing unprecedented global threats and where we've got real pressures on defence spending, Deputy Prime Minister who's trying to build 1.5 million more homes because you've got kids in temporary accommodation, a Work and Pension Secretary grappling with rising levels of child poverty, a Chancellor who's having to balance all of those competing interests and worry about the finances of every family and every business in the country, and a Prime Minister having to worry about all of those things combined. So these are not easy challenges. I don't say that by way of complaint. I sometimes say to my colleagues, look, it's no good us going on the telly and saying, oh, we've got tough choices, because people will say, well, of course, that's why we chose you, to kind of do it, make those tough choices. So don't worry, we're not feeling too sorry for ourselves in government. We wanted this task and we've been trusted to deliver, and we will. But in the spirit of getting this right and building the partnership we need, we all need to, as a country, to be honest about those choices, those trade-offs. What do we really want to prioritise? And I think that's where Keir's mission-driven approach to government is really helpful, because it sets out what those missions are, but also the sense of partnership we need to build, because government can't do this alone. It's not all on us. We have to do it with business, with civil society, and with all of us as citizens. And that requires all of us to be honest about the choices, the trade-offs, what we can afford, what we would really prioritise, what we're prepared to say stop to, what we're willing to say no to. And that is not always going to make us popular, but I'd just say, thinking about some of the unpopular decisions we've made in the last 7 months, if we just said the things to crowd please, and we duck the difficult decisions, no one would thank us in a few years' time when things got worse.
See, the great difference between this and the Today programme is, if it were the Today programme, I would say, what are you going to say stop to? What are you going to say no to? But I'm not. I'm going to say thank you very much.
Well, I just halved a load of targets in the NHS planning guidance. That made me really popular.
So we've already got ahead. Let me just say, before Gemma comes up, very, very briefly, which is, I think we've heard from people with experience, the room's full of them. And I remember agreeing to speak at a conference like this in Glasgow and then pulling out and saying to the person who'd invited me, frankly, there's no point you hearing me. I don't know anything that doctors and nurses and people don't know. And I've always had in my mind what someone said to me, this nurse. She said, never, ever do that again. Never devalue your experience as a patient. Never devalue what you know. We appreciate what you know as a cancer patient and the efforts you're making, and I think you've appreciated what you've heard today, so thank you very much indeed.
Thank you very much.
Thank you to you both. That was, I was listening avidly and taking notes. It won't surprise you to know. My reflections really are of a lot of hope, I think, in the room. I heard lots of things which gave me cause for real hope. I think we all know that cancer is a defining health issue of our generation. It will be of your legacy, Wes. If we can't get it right in cancer, we're not going to be able to get it right in anything else. Look at the assets in this room. We've got more data in cancer than anything else. We know how to do this. I think everybody in this room knows where the gaps are between what great looks like and what the worst looks like. I think some people know that because they fell into those gaps and they pulled themselves out and they tried to make it better. Like, that is the energy and the experience that we're going to need in this cancer plan. I think I heard a really strong call for us all to come together and to maybe put aside perhaps some of the baggage that we've got from things that have happened in the past. You know, some of the, will the big charities trample all over the little charities, or will we see the Secretary of State again? Or will, you know, are the commercial people in the room trying to profit out of people with cancer? Like, all of that baggage we need to leave behind, because actually this team is really mighty. Like, we've got a mountain that we've got to climb, but we are brave, we've done it before, we are strong when we come together. And for me, that's the real hope of what I've heard today, is that there is an opportunity for us in this plan to make some of the big shifts that we know that we need to make so that things get better right now for people with cancer and for people that come after us. That the game is changed fundamentally so that we are proud of the cancer care that you get in this country. And that is what everybody in this room wants, for it to get better today and better for tomorrow. Huge thank you to both of our panellists, to Nick, who has to get up early most mornings to be on the radio. He didn't have to get up early this morning, but he chose to come and be with us, so we're hugely grateful. And to Wes, Secretary of State, we know there are many rooms that you could have been in today. We know that there are lots and lots of calls on your time. We know that your job is not easy. And we are hugely grateful that you have been here and that you have answered in the way that you have, and that I think we really see in you a passion and a drive to do this differently, and we are absolutely with you and want to partner with you on that journey. So thank you.
Thank you.
And to everybody that doesn't have to rush off, please stay for a cup of tea and coffee, refreshments, time to chat and connect. Everybody who you're sitting next to is interesting and worth a conversation. So please stay. Thank you.